show you some genetic predisposition factors which cause dermatological disorders. Is there anyone who can name me just general feature which can lead to a dermatological disorder?
Autoimmunity.
Okay, but that's not a general feature. Sorry? Rashes. Okay, and how? What is the general feature for having rashes? Yeah. Okay. Well, it's a good point, but I will come back to that later. But it's one general feature which is very common. I can show you. That's this: a fair skin, and usually it's associated with red hair. And what can it lead to? Skin cancer. Yeah. On top you see a melanoma, and below you see a basal cell carcinoma. So, and how does this occur? That's of course exposure to sun, to UV light. Yeah, and this is a damaging factor. So, how can you protect yourself against UV light? It's just having a dark skin. That's also a genetically factor to protect yourself. Well, and if you look at the UV index of the world, you can also see where the dark skin is living and where the fair skin is living. Because if the UV index is high, you see dark skin. And in the north and in the south, where UV exposure is less, you generally see white skin. So you can also wonder, why do the people develop white skin? Anybody has a clue? Why do people in the north and here have generally white skin? Exactly. I mean, if you have less exposure to sun, you can't make too much vitamin D. So you want to have a light skin to catch all the sunlight you need. Yeah. So that's probably it's probably an evolutionary feature which we developed to catch all the sunlight we need to make enough vitamin D. And of course, the people where there's enough sun, they don't need that. They have enough sun exposure anyway. So there are also genetically predisposing factors which lead to skin cancer very soon in life. And I can show you one genodermatosis, so that's an inherited skin disease, which early in life you develop basal cell carcinoma. But here you see an example of a gentleman who didn't see a doctor for a long time, and so he walked around with a basal cell carcinoma for a long time. Usually it's not metastatic, but if you walk around too long with this, you will lose your nose in this case. But there is also a disease which causes early in life basal cell carcinoma, and that's this disorder. It's called basal cell nevus syndrome. It's also known as Gorlin syndrome. And Well, you can see here already a picture of this a man who has this syndrome, but it has many more features. Yeah, on top you see the increased incidence of basal cell carcinoma. But below you see other features which are also associated with this syndrome. And the previous pictures you saw the pits in the palms of the hands. But you see also that the cysts may develop, but also developmental disorders you develop, like the cleft lip, for instance. Well, this disease is an autosomal dominant disease, so you actually need only one mutation to get the disease. And it's located on chromosome, the long arm of chromosome 9. And the gene which is located there is the patched gene. And it's the homologue of Drosophila patched. So mutations in this gene cause this syndrome. Well, what does patched do? Patched is a membrane-bound molecule, and it's an inhibitor of smoothent. Well, you can see like here a cartoon where the Sonic Hedgehog pathway is depicted. On top you see SHA is the Sonic Hedgehog ligand, which binds to the patched molecule. And if this ligand binds, patched will inhibit smoothent. And smoothent is actually an activator of the Sonic Hedgehog pathway. So it's activating GLI, which is a transcription factor, and it drives genes which are needed for proliferation. So you can imagine if you have a defect in patched, that this pathway is disrupted. Well, the BCCs in basal cell nevus syndrome show loss of heterozygosity. So it means one copy is already knocked out. But to develop basal cell carcinoma, you need the other copy, the wild type copy, needs to be knocked out as well. So inactivation of patched is probably a necessary, if not sufficient, step for tumor formation, in this case basal cell carcinoma. But also other malignancies develop in this syndrome. Well, and as you know, this was a theory by Knudsen, the two-hit theory of carcinogenesis. And you can see pictures there how it works. So you have in a germline mutation in this patch gene, and later in life you lose the second wild type copy. And below you can see that. And then you develop tumors in, like the basal cell carcinoma. Okay, so you can actually say that patched is a kind of a gatekeeper of tumor formation. So, because if you look at sporadic basal cell carcinoma, which is very frequent in the general population, probably like you sit here in the audience, probably about 5 or 10% of this audience will develop basal cell carcinoma somewhere in life. So it's very frequent. And so in the sporadic basal cell carcinoma, you also find mutations in patched and smoothed. So this pathway is also involved in the sporadic cases of basal cell carcinoma. And so you may say that patched and smoothed are the gatekeepers of basal cell carcinoma. Well, I put like a butterfly because this is known as a gatekeeper. Well, so the hedgehog pathway, yeah, if you look at the hereditary cancer predisposition and developmental disorders, this pathway is very important. And if you, sometimes you find accidental discoveries, and you can learn from nature. If you look at drugs which come from nature, those are many. Well, this is a coffee plant, and this is also kind of a drug. But this is also one which was discovered in nature, because what happened, sheep, in this case in the United States, were eating of this corn lily. And in this plant there is a toxin which is called cyclopamin, and these sheep, they delivered babies, I don't know how you say it in English, lambs, with developmental disorders, and you can see that here. You see a cyclope. So this sheep has only one eye. Well, and what does so this was an accidental discovery, but what does cyclopamin do? And actually, it's an inhibitor of smoothant. And if you know this, you can also explain it. And because patched is usually doing this, and patched is very important also for developmental, your development. So if you knock this out during developmental stage, or in this case in the sheep, this pathway is not on or off when it's supposed to be on or off. Well, so smoothant is actually a key protein for embryogenesis, and it needs to be on or off at certain stages in developmental life. But it's also very important in oncogenesis, because if it's always on, then you develop cancer, and usually basal cell carcinoma. Well, this is also a disorder, and I didn't put like the horrible pictures here. This is just a baby which is born with holoprosencephaly. And actually, in this disorder, you also find mutations in patched. And well, these are usually different kind of mutations. If you have like truncating mutations, so that the protein stops prematurely, then you usually develop basal cell Nevi syndrome. If you have missense mutations, you usually get this holoprosencephaly. And it's also autosomal dominant. And well, you can see there also that's a kitten, and it's a cyclope kitten. Yeah. And well, the extreme cases of in humans also you see cyclopes. So, but I didn't put these pictures because they are horrible to watch. But in that case, so I went to an animal model for this. In this case, the holoprosencephaly is actually a disorder where the hemispheres don't separate correctly. So okay, so this is so here you can see the two key factors in the sonic hedgehog pathway. Smoothant needs to be on or off at particular moments, otherwise it goes wrong. And it can be at a developmental stage, but it also can be later in life in oncogenesis. Well, this cyclopamin is actually may be a very suitable drug to treat patients with basal cell nevus syndrome, because patch is knocked out in this basal cell carcinoma, and if you inhibit smoothed by cyclopamine, you have the same result. You turn off this pathway, and in that case you also turn off the proliferation which is needed for basal cell carcinoma growth. And it actually also works very well for these patients, and in particular in basal cell nevus syndrome. And you may wonder, maybe it also works for the sporadic basal cell carcinoma. And because the same molecular pathway is involved. And actually this is the case. It does work also for the sporadic cases of basal cell carcinoma. It also depends a little bit if the basal cell carcinoma which you treat has where the sonic hedgehog pathway is involved, then it works. If other pathways are involved, then it doesn't work so well. Industry already has developed a kind of molecule which looks very similar to cyclopamine, which even works better for the sporadic case of basal cell carcinoma. So, in this case, skin cancer, if you elucidate the underlying molecular mechanism of a rare disease, in this case basal cell nevus syndrome, it gives also a better understanding of the more frequently occurring disease, the sporadic basal cell carcinoma. And in this case, by, for instance, the cyclopamine, you also may develop treatment opportunities. So, doing research on rare diseases may also benefit more frequent occurring diseases. Well, even better is of course preventing skin cancer. Put a UV filter on your skin or stay out of the sun. The best option is actually completely stay out of the sun. Then you don't develop skin cancer. Well, so this was one predisposing genetic factor which may lead to a dermatological disease. Do you know another example? And you already mentioned something, it's in that line, but what is a very general feature in the normal population which may cause itching, for instance? Sorry? Eczema? Eczema, yeah, but something before eczema? No? Actually, if you have dry skin, it's a very common feature in the population. And it looks something like this. And it can be in all, maybe severe or mild. But it's a very common feature in many populations. And dry skin, may cause itching, and you may develop eczema, which is also very common in the normal population. Well, is eczema genetic or not? You may wonder. If you look at twins, and identical twins, you see a high concordance, almost 80%. You see if one baby develops eczema, the other probably does too. In dizygotic twins, you don't see that, but there is like a 20% chance that both children will also develop eczema. So there is, in this case, you may say, well, it's probably some genetic factor which may predispose to eczema. And how does this look, this disease? Here you see a baby, and you can see these red rashes, and also here in the cartoon on top, you see where it usually occurs, and it's usually in the well, how do you say that? The fascia, the groins, right? So and that's like an there's usually warm and moisture climate there, and there it develops. Well, and actually the skin needs a barrier to protect yourself against, well, antigens, moisture loss. So, and if you look at this barrier, which is called the stratum corneum, it consists of some components, and that's a lot of lipids, which also moisturize your skin, ceramides, cholesterol, and also long chain fatty acids. So this creates an impenetrable barrier for your skin. But to develop eczema, you need more than just one component usually. It's like a fire which needs to get going. You need multiple factors to cause the rupture of fire. And it's the same with eczema. So, yes? This? Oh yeah, sorry. Yeah, well, to get this fire going, you need fuel, energy, a catalyst, oxygen, and the proper mixture. Otherwise, this fire won't erupt. Yeah, it's just an example. For the fire, you need to see as like eczema. When does this eczema rash start? You need multiple factors. And you can see that here too, it's like a balance. Yeah? If the balance is in equilibrium, you have normal skin. But if the balance tips, you may develop eczema. And there are a lot of factors involved in this. And there are, of course, environmental factors, but also genetic susceptibility. And you may tip the balance again by using ointments to close your skin barrier again. Okay. And there are some also drugs on this scale, like anti-pruritus, so anti-itch drugs. Things are like the immune suppressant ointments, so you can tip the scale back in balance. Okay, well, so back to the barrier of the skin. What is the genetically predisposing factor to by developing dry skin? And there is a disease called ichthyosis vulgaris. Vulgaris is like general, and ichthyosis is like a scaly skin. And it's usually an autosomal dominant, but the brackets I will explain in a minute. And this is how it looks like. And it's very common. It's 1 in 250, between 250 and 400 people does have this extreme dry skin. You see that on the left, it's extreme dry skin, and you see also this scaly skin. So that's the ichthyosis you see. Here on the bottom you see this cracking of the skin, very dry skin. There are also other features, like if you look in the palms of the hands, you see very many lines and deep lines in the palms of the hands, and it's called hyperlinearity. It's also, it doesn't always need to be there, but usually you see it very often with this disease, associated with this disease. Well, here you see a family tree of a family with this ichthyosis vulgaris, and it says a semi-dominant inheritance, because you can see, you don't look at the black individuals, but you should look at the asterisks. Yeah, so one asterisk you have mild ichthyosis, two asterisks you have marked ichthyosis. Yeah, and if you look at this family tree, you might say, well, it's dominant, but well, it's not. The penetrance of this disease is not complete, because sometimes you see mild, sometimes marked ichthyosis, so it's variable. But looking at the family tree, you probably think it's dominant. Well, if you look at histology of the skin of these patients, and you see that in the below pictures, you see something which strikes your attention. I don't know if you see it. If you compare it with the top panel, you see a patient with a different kind of ichthyosis, which is the ink-linked recessive ichthyosis. You see a difference. You see the ichthyosis, the stratum corneum, the thick stratum corneum layer. I don't know if you here. It's also seen here. But you see something different. And that's this layer, which is a general feature of the epidermis. It's a granular layer. And here, in this kind of ichthyosis, it's still there, but here, you don't see it. It's gone. And you can also see that with the electron microscopy. These granules, you can see here on top, as these black spots, and here you don't see them. Or, well, they are almost gone. And these granules are the keratohyalin granula. And these granula consist mainly of filaggrin. And so it's the main component. And it's not actually filaggrin, but a precursor of filaggrin. It's a profilaggrin. And filaggrin, the name of filaggrin is derived from filament aggregating protein. And I come to that later. And it's a very important protein for epidermal differentiation, and also for creating this skin barrier. It's also present in the oral and nasal mucosa, besides skin, of course. And it's very important in forming a flexible skin, and also hydration of the stratum corneum, so the top layer, the upper layer of the epidermis, the stratum corneum. Well, this publication was published in 2006, it says, 2006, where they identify the genetic cause of ichthyosis vulgaris. And it says actually that you need to lose both copies of the filaggrin gene to develop ichthyosis vulgaris. And here you see again a picture of a patient. But actually, so it turned out that the autosomal dominant form, which we always thought it was, of ichthyosis vulgaris, is actually an autosomal recessive disease. And if you go back to this family tree, then and you do the mutation analysis, you can also see that if you have mild ichthyosis, you only have one mutation. If you have the marked ichthyosis, both mutations of both filaggrin genes are knocked out by a mutation. And so now you can see that actually ichthyosis vulgaris is a recessive disease. And in this family, you see that two mutations are causing this disease. Well, no, yeah. One. So there are actually two different mutations in this family tree. So homozygous mutations for this mutation, and here you see compound heterozygous mutation. But always, if there are two mutations present, you see marked ichthyosis. Well, how does filaggrin, how does it look like? The gene you see on top, so it's actually a very strange structure of the gene. It has 3 exons, and the 3rd exon is very large. And it consists of repeated units. Well, if the gene is translated into protein, into profilaggrin, you see that there are some different possibilities depending on what gene you carry with you. It might be that you have 8 repeated units, or no, 10 repeated units, and or it may also be 11 or 12. So that's already variable in the population. These units are extremely identical. So they are almost 100% identical. And but there are also a lot of variations in these repeats, so the single nucleotide polymorphisms. And that's why it also, because the granular layer that is not present in Ichthyosis vulgaris was already known for a long time. But nobody could find mutations in this gene because it was very difficult to analyze. And that's because of these repeated units. It's almost impossible to determine the genetic code of this whole gene. So that's why it took so long. And actually this filaggrin is located in the epidermal differentiation cluster, which is actually a very large region, about 1 megabase, located on the long arm of chromosome 1. And there are many genes in this cluster which are important for epidermal differentiation. Well, what can go wrong? Because you already saw that there are mutations found in this filaggrin gene. And here you see a schematic representation of how filaggrin, amongst other proteins, build the epidermal barrier. Well, I hope I can. I don't have a pointer, but so I hope like this. Here you see profilaggrin. This protein needs to be processed. You need proteinases for that. Here you see a proteinases with cleaves profilaggrin in the filaggrin units. You can see that here. Well, this the N-terminal part of this protein will translocate to the nucleus. What it does is not known so far. You also have inhibitors of these proteinases. One of them is lectin. So then you will have the single units of filaggrin. You can see that here as these green boxes. These filaggrin units, they will cross-link with keratin. You can see that here. And keratin is the cytoskeleton of the cell. It also needs, for this process, cross-linking, so you need transglutaminases for that. You can see that here. And then after a couple of more processing steps, you will end up with the natural moisturizing factors, which are derived from the filaggrin protein. And that gives also your skin the moisture you need to create a proper epidermal barrier. Well, if you have mutations in filaggrin, you know what happens. You get ichthyosis vulgaris. But there are also other dermatological disorders in this pathway which lead to disease. And this is one. If you have, this is a recessive disorder, if you have mutations in this inhibitor of this proteinase, then you will develop Netherton syndrome. And this is an extreme form of like eczema. If you have mutations in this proteinase, which cleaves the profilaggrin molecule, you also see an ichthyosis on your skin, flaky skin. And there are also other features like hypertrichosis to it. That's baldness. You lose your hair. If you have mutations in the keratin genes involved in epidermal differentiation, you get this. Epidermolytic ichthyosis, also again ichthyosis, but you also see bullous, how do you say them? Blaren? Blisters, yeah, right. But this is only in the beginning at birth, and then it will disappear. It will still stay in the groins, the blisters, but the rest of the body will become an ichthyosis, so flaky skin. Well, the cross-linking of this filaggrin with the keratins, there are also transglutaminases involved in that. If you have mutations in those genes, you get this. It's also a form of ichthyosis, but it's a lamellar form of ichthyosis. So you have very thick, scaly skin. Well, back to the filaggrin gene. If you look at this gene and you look in the general population, but also in single patients, you find many mutations. And you can see that here. But they are also clustering in certain populations. So on top you see the mutations which are found in the European population. And in below you see the Asian variants. And probably in other parts of the world it will be different mutations altogether. But what, if you look at these mutations, I don't know if you can read these mutations. Then you notice something. What does the X stand for? Does anybody know that? For instance, in here, R501X, where does the X stand for? Yes, a stop. So it's a nonsense mutation. And if you look at other mutations, you see that it's usually always a nonsense mutation. Or it's a frame shift mutation. Yeah, for instance with the deletions. Because then the frame shifts and eventually it will cause a premature stop. Yeah, so the proteins, they are all prematurely truncated. so shortened. And it's always the case. All mutations involving in this disease are all truncating mutations. So you don't see missense mutations. And it turns out that the two in the beginning of the gene here, this one and this one, is very common in the population. Here you can see which mutations are found more often. So on top you see these two mutations, which are in the European population, but also in the American population. But of course, yeah, the Americans are the immigrants from Europe, so that's no surprise. But sometimes you see also mutations which only occur in one family and are not found frequently. And of course there are certain mutations which you only find, for instance, in the Asian population and not in the European population. Well, how can so many different mutations cause the same disease? Because if you have a truncating mutation all the way at the end of the gene, which you can see here, the 11,033 deletion there, it's all the way at the end of the gene. But then still you have filaggrin repeats. So you should have some filaggrin left to build up this barrier, the epidermal barrier. But this is not the case. And you can see that also there. That's a Western blot. So you separate the proteins in size. You can see that in normal skin you see profilaggrin, yeah, on top here, profilaggrin, and the process form, filaggrin. Here you see a homozygous mutation in the beginning of the gene, and no wonder that you don't see anything, because it's already before the filaggrin repeats start. But here, well, in the middle, you see a compound heterozygous patient. And also there, you do see a little bit of profilaggrin. I don't know if you can see it, but here you see a little bit of profilaggrin. So profilaggrin is there, but you don't see anything of the process form. So actually the C-terminus of the protein you need for proper processing to the filaggrin units. Yeah, and that you see here. The green part there is necessary for this proper cleavage. Well, and you can also see this histologically, because if you just use an antibody against filaggrin, yeah, you can see in normal skin that these granules, they stain, because that's profilaggrin what you see, and filaggrin. If you do that in a patient, you do see a little bit of staining, but actually this staining is not the separate units of filaggrin, but this is actually the truncated profilaggrin what you see. So there is a little bit there, but it's not properly processed. Well, if you look at this disease, ichthyosis vulgaris, and you ask these patients, they usually have also atopic dermatitis. So 3/4 of these patients do develop, for instance, eczema or other disease associated with atopic dermatitis, like rhinitis or allergies or asthma. If you go back to this family tree where they discovered ichthyosis vulgaris, then now you can now you look at the black symbols. You also see that segregating with a mutation, atopic dermatitis is also segregating. Yeah, not always, but in most of the cases you see an association with the mutation and developing atopic dermatitis. Well, if you know that, then you can wonder, well, maybe the general form of atopic dermatitis is also associated with mutations in filaggrin. And that's true. Because this was a publication 1 month later, and they screened a lot of patients which just have atopic dermatitis, and it turns out that in a lot of these patients you find mutations in filaggrin. And it's very common in the population. Almost 10% of the population develops some kind of eczema or has some kind of atopic dermatitis. And this is how it looks like. And it's usually not always develop eczema, but it may come, it may go, but it is there. And this is what are the features of atopic dermatitis. So you see eczema, which is actually a form of skin inflammation. But you see also this dry skin, which is very general in the population present. And also ichthyosis, mild or marked. You see itchy skin, pruritus. Keratosis pilaris, I don't know if anybody knows what that is. You have a kind of goosebumps on your skin. And you see allergic reactions like hay fever, for instance. But also asthma, which is also an atopic feature. Well, and you see other food allergies, and also here you see also again this hyperlinearity on the palms of your hands. So if you look at your hands and you see a lot of lines, you may wonder, and you had early in life, for instance, eczema, you may be carrier of a mutation in filaggrin. Well, there are some other signs also, but they are not always there. So, atopic dermatitis is a multifactorial complex disease. That was what they always thought, and it still actually is. And it was always considered an immunological disease, because you see the skin inflammation, which looks like the eczema. So they thought, well, this probably the immune system is involved. And already for a long time they tried to map genetic loci on the genome and see where a certain gene may be located for developing atopic dermatitis. Well, and filaggrin now is the first gene which is actually associated with this disease, and it predisposes to atopic dermatitis, but also asthma and other allergies. But to develop eczema, for instance, you not only need a genetic predisposition for developing this disease, but you probably need also environmental factors. And we come back to this fire. To get this fire started, you need multiple factors to get this fire going, to develop this eczema. And that might be, that's not only genetic, but it might be also the environment. And it tends to be that eczema is much more pronounced now than, for instance, 50 years ago. And it might be due to like central heating, dry air, or the hygiene, washing your hands every day with soap and all things like that. It dries out your skin. So there are more factors involved, not only genetic, to develop eczema. And this is actually, what we think is now the cause of eczema. And that's not primarily an immunological response, that's probably secondary. It doesn't mean that the immune system is not completely involved genetically, but the barrier is the main feature of keeping the antigens out because if antigens enter the skin, what you get? An immunological response. It's just a common response of the body. So if this barrier is like leaky, the antigens come in much easier and you will get an immunological response. If they stay out, the immune system will also stay quiet. Well, the frequency of filagram mutations is very high. In the normal European populations, and actually in the Netherlands it's a little bit lower, but these figures are from the United Kingdom, and 10% of the population has a filagram mutation. And that's why also eczema is so common. But how is this possible? Because we always learned if you have a mutation, you are probably not a survivor, because you are not fit. Survival of the fittest. How is it possible that these mutations stayed in the population?
I thought they survived the pest of the plague. Because it came to their skin and they were pre-sensitized with it.
Yes. Well, that's a hypothesis, but probably that's the case, because this is an example of a mutation which is fixated in the population, because it protects against malaria. And you can see that sickle cell anemia is also occurring where the malaria mosquito is occurring. And this is probably also why this filagram mutation is still there.